These are the 4 operations that I perform in my practice. All of the operations, through slightly different mechanisms, have a prolonged effect on the appetite, allowing people to eat less food without feeling very hungry. The sleeve gastrectomy is the most commonly performed operation in this country, and the mini gastric bypass accounts for most of the remaining weight loss surgery done as a primary procedure. The focus of this video is the mini gastric bypass. In this operation, 5 small cuts are made in the abdomen, and through these cuts we pass instruments, we identify the stomach, then we make a window in the fat on the lesser curvature of the stomach. That allows us to pass a stapler, and that passes partway across the stomach so that we can start to develop a long, thin, tube-like pouch of stomach. The anaesthetist passes a tube down through the mouth that sits in that tube that we're creating and helps to make sure that we're making the tube of the right diameter. We want it to be long and thin to minimize the risk of acid and bile reflux. A little hole is made at the bottom end of that pouch of stomach before measuring out the small intestines. Most of us have got around 7 meters of small intestines, and we bypass just the first 160 to 200 centimeters or so of the small intestines. Once we've counted that out, we make an opening in the small bowel, and we pass one part of the stapler into that, and the other part goes into this hole in the stomach that we'd previously created. We then use the stapler to form most of the join. This leaves behind a little hole that we need to stitch up. This is relatively straightforward, and this whole operation takes just over an hour to do typically. Because the opening is nice and wide, any build-up of pressure in the stomach pouch should dissipate out into the bowel, so we see much less reflux associated with this, and it also means that there's a quicker return to food than with the sleeve gastrectomy. At the completion of the procedure, the anaesthetist passes the tube all the way into the small bowel to prove that things are open and to double check that there's no leak from the join that we've created. So once this is performed, the food will come down through the gullet into the long thin tube of stomach before passing into the small intestines. The food heads off towards the lower small intestine, whereas the digestive juices have to play catch up, passing through their own loops of bowel, and don't meet up with the food until the level of the join. Digestion then happens in the lower part of the small intestine, and this strongly promotes a number of hormones that are powerful appetite suppressive hormones, and for patients with type 2 diabetes, it improves their sugar control such that quite frequently patients with type 2 diabetes are cured of their diabetes with a bypass operation. It gives a quick return to food because of the low pressure tube, unlike the sleeve gastrectomy, which takes several weeks before people can eat solid food. It's pretty easy to live with for most patients, and there is less chance of troublesome heartburn or reflux than we see in the sleeve. It can still occur, and about 1 in 20 people will suffer some reflux after this surgery, and those people will mostly be able to be controlled with anti-acid treatments. Sometimes though, about 1 in 40 patients will have bad bile reflux, because the bile in this setup can make its way up through that long thin tube occasionally to burn the esophagus, and that requires a simple but extra operation to make it better. And that operation essentially just joins the bile bowel to the food bowel, giving a shortcut so that the bile can't get up into the esophagus. About 1 in 20 people historically developed an ulcer from this operation at the joint. In order to prevent that, for 6 months after surgery, everybody must take an antacid tablet each day. This dramatically reduces the risk of developing an ulcer at the joint. Smokers get very bad ulcers, and I won't perform bypass surgery on smokers. The other aspect of this operation is that it does change the way our digestion works, and that can have consequences. Firstly, there are some things that are best absorbed in the early part of the bowel that's been bypassed. That includes proteins and some vitamins and some micronutrients. So it's very important that if people have this operation, they have a reasonable protein intake, which will be guided by the nutritionist. They must take a multivitamin every day, and we closely monitor their vitamin and trace elements through blood tests, particularly in the first couple of years until things have stabilized. The other effect of changing the digestive system is that usually people's bowel habit changes slightly. It does not usually become problematic for them, but it tends to drift towards the looser, more frequent stool end of the spectrum. And some people have smelly or more offensive stool or when they pass wind. Mostly these things can be improved with modifications of the diet as guided by the nutritionist. Very rarely, around 1 in 100 people will have either troublesome diarrhea that doesn't respond to dietary and medical management, or a deficiency in a vitamin or trace elements such that we would need to reverse the operation. That is possible to do, but it's large extra surgery. Another potential problem with bypass operations, particularly stomach bypass operations like this one, are that some people develop what's called dumping syndrome. This is an over-response to sugary foods, particularly refined sugars, and is mostly managed by avoiding taking refined sugars. It can be set about by fruits and things like that though. People will lose weight after the surgery, usually for 12 to 18 months, and then find a new stable weight. It's very important that for the best long-term outcomes, they continue to follow up with their surgeon and nutritionist as required. And the more people put in, the more engaged they are with their weight loss and their health, the better their outcomes are going to be, and the less chance of problems such as malabsorption of vitamins or proteins in the future. The operation's performed with at least a 1-night stay in hospital. Most patients end up staying 2 nights in hospital. Prior to hospitalization for the surgery, people need to take a very low calorie diet. Usually the backbone of that is something like OptiFast. The nutritionist will guide you as to how to get through that period. The purpose of that 2 weeks before surgery is to shrink the liver of some of its fat to make the surgery possible to do by pushing the liver aside. After the surgery, people go home on a liquid diet and progress to solid food, usually by the 2nd or 3rd week after the surgery. Well, I hope you found that helpful. You can access lots of information on my website, but we'd love to hear from you. You can get in touch on my email or during business hours on the phone number.